and I hope the message will be clear. Our objective will talk about brain ultrasound as a B mode, and we'll talk about brain ultrasound as Doppler. This is a great review in article of Intensive Care Journal, April 2019, talk about brain ultrasonography, methodology, basic and advanced principle, and the clinical application. Very great review. Talk about everything. My lecture, this will be the main reference of my lecture, and to talk about the evidence-based application of critical care ultrasound for assessment of the brain. This is my case report and review articles in the previous year, talking about the brain ultrasound and the TCD, and I will use it in my lecture. First, brain ultrasound as BMO. For the doctors here who are not used to use ultrasound, I need, in brief, I talk about the physics. What is the B mode? Use of brain ultrasound as B mode, that means we need to use the brain ultrasound to look for the brain tissue, to see the brain tissue. And very simply basic, the ultrasound probe emit ultrasound beam, and at the same time, this intelligent probe will receive the reflected ultrasound from the tissue. This reflected ultrasound, when the ultrasound emitted to the brain, it will face different structure and will get reflection from each structure. And the rule of ultrasound is, if too much ultrasound beam is reflected, if too much ultrasound is reflected back to the transducer, the image will appear white, hyperechoic, like bone, pleura, and pericardium. And if the ultrasound beam, which reflected from the brain tissue, is very low, the picture will appear anechoic, will appear black, like water and blood. And if in between, it will appear gray. So the basic B-mode ultrasound, which you see in the screen of the ultrasound, is degrees of gray according to the reflected ultrasound waves from the tissue. As you see here, if too much ultrasound beam is reflected, the image will appear hyperechoic and white. This bone, pleura, pericardium. This is a skull bone. The reflected ultrasound from the skull will be too much because the density of the skull is great, and this will appear as white. And the same with the pericardium here, is very good reflector. Too much ultrasound is reflected from the pericardium, will appear white. But in the contrary, the reflection of ultrasound from the water, like urine in urine bladder and blood in inferior vena cava, will be very little and will appear black. And in between will appear gray, like reflection from the liver, reflection from the spleen and the kidney, they appear gray. And the ultrasound image which appear in the screen is this grades of gray according to the reflected ultrasound beams, according to the density of the reflected tissue. As you see here in this image, you see no reflection from the bile, appear black, and too much reflection from the stool, which is there a lot of calcium, appear very white and echogenic, and in between the liver, there is moderate reflection. This is as a B mode. This is what's meant by B mode. We are using the brain ultrasound to look for the brain tissue. How to do it? Very simply, you will use the phase array probe, the echo probe, which will adjust to 2 megahertz. And you will adjust the depth to 13 to 15 and will make the focus at the midline. you will put in the brain ultrasound, we are using the temporal window, which is in front of the ear, above the zygoma. You will see this temporal bone, which is thin bone. We'll use this temporal bone as a window to look for the brain tissue. You see here this open skull from this great image in the stroke article. You will see here the probe in the temporal area, and the ultrasound beam will be directed in this direction, will explore the brain tissue as well as the blood vessels. As you see here, we are using the temporal window, which is present in the temporal lobe. So the ultrasound beam will be directed here in the midbrain and the brain stem. Okay, you know now you will use the phase array probe, and it's not too much windows, only one window, which is the temporal bone above the zygoma in front of the ear. Where do you see your target? What are you going to search? Where is the area you search? Once you put your probe in the temporal window and you will fire the beam mode of brain ultrasound, you will see first, there's 3 levels. The first level will be the midbrain. So please, you are here in the left temporal, and you will see this butterfly area of the midbrain with wing looking anteriorly. And as you see, now I'm not looking for the blood vessels, I'm looking for the tissue. You see here, the midbrain appear hypoechoic, and there is white matter appear white, and the gray matter appear gray, and the bone appear hyperechoic. As you see here, this is the CT pictures, but I make it on the side to see. This is the anterior, this is posterior, this is the midbrain, this is the midbrain, this is the temporal window, as you see here. So, number one, once you put the probe in the temporal region, you should see this midbrain. This is your guide in the brain ultrasound anticity. Without seeing this midbrain butterfly area with wing anteriorly, you cannot complete your study. After getting this great beauty midbrain, just tilt the probe up, tilting the probe up. That's why, because if you see this brain anatomy, this is the midbrain, and tilting up, you will see the third ventricle with penile body posteriorly, and if you tilt up again, you will see the lateral ventricle. And these are the 3 levels you need to explore. If I tilt the probe up from the midbrain, you will see this third ventricle, which is tubular-like structure with anechoic CSF inside and the hyperechoic wall with a great landmark, which is the calcific penile body posteriorly. Okay, and this is the corresponding CT picture, third ventricle from the temporal window. Just you look for the midbrain, tilt up to get this third ventricle. This is the second level. After that, you tilt up again, you will see this lateral ventricle, and this is the CT image. And if you see, I will see you just tilting. If I get this midbrain, I am tilting third ventricle after lateral ventricle. Just tilting, very simple maneuver. You will put the phase array probe in the temporal window, and after that we are going just to tilt to dissect the brain in these 3 levels: midbrain, third ventricle, and lateral ventricle. This is the 3 areas you need to explore as a B-mode ultrasound. What are you searching for? Now you know how to apply what type of probe, how to apply the probe, where to apply the probe, and where is the level, what is the levels you are exploring as brain ultrasound as B-mode. As we just talked about B-mode, we are searching for the brain tissue lesion. What is the normal brain tissue? In B-mode, you are seeing normally in brain, you will see anechoic CSF in the ventricle, and you will see gray hypoechoic of the midbrain and the brain tissue, and hyperechoic bone. This is the 3 grade of echogenicity you used to see in brain ultrasound. But if you see abnormal echogenicity like that, you see this is abnormal echogenicity. It is less than bone, but probably more than brain tissue. This is hematoma. This is your target. You are searching for abnormal echogenicity other than the CSF and the brain tissue and skull. Number 1, using brain ultrasound as B mode, you are searching for abnormal echogenicity. TCCD, brain ultrasound, can identify and differentiate between intracranial hematomas and ischemic stroke, with hematomas being hyperechogenic, white, and ischemic lesion hypoechogenic. As you see here, this is the 3rd ventricle. We are, while we are talking about the 3 level of B mode brain ultrasound, we'll talk about the 3rd ventricle. And as all of you know, the 3rd ventricle, all around the 3rd ventricle, in 2 sides, there is a thalamus, there is a basal ganglia, there is a temporal loop, and with tilting up, there is a parietal loop. All these areas are the area of hemorrhage. So these are accessible for ultrasound assessment. As you see here, if you see here, you see a frontal hematoma in the right side, and with ultrasound, there is hematoma here, the probe on the left side, and this is the right side. You see hematoma very clear. Here is the hematoma, hyper dense in the 3rd ventricle and in the lateral ventricle, and here. And when I do the brain ultrasound, I see hyperechoic area in front of the midbrain, and here in the left basal ganglia, and here is the right. Here is the 3rd ventricle. Here is the left basal ganglia, hyperechoic lesion, hyperdense lesion. There is correlation between both lesions. And with more experience, you can see cerebral hemorrhage in almost all areas of the brain. Look for this. Look for this. This patient, this is here my probe in the right temporal region. Here is the 3rd ventricle. Here is the middle cerebral artery. You see here, there is hyperechoic lesion here in the left area, just below the bone. And if you see, there is epidural hematoma. And in this patient, you see there is ventricular hemorrhage. And if you see the 3rd ventricle here, there is hematoma moving inside the 3rd ventricle here. Hematoma hyperechoic moving inside the 3rd ventricle, as you see in this clip. And this patient has subarachnoid hemorrhage with hyperdense area of blood in the quadrigerm cistern all around the midbrain, and with brain ultrasound, as you see here, this is the midbrain hypoechoic, and there is hyperechoic area all around, which is the blood in the quadrigerm cistern. And as you see here, even the posterior cerebral artery, you see here very clear 1st or 2nd part, and you can swear there is no aneurysm in the posterior cerebral artery here in the left side. Number 2, you will look for the ventricular system. You can assess the diameter to diagnose hydrocephalus and interarticular bleed, as you just said, and midline shift. This is the view of the 3rd ventricle in the CT, and this is the 3rd ventricle in the brain ultrasound. It's correlated with the CT, and you can measure the size and diameter here, and it's correlated well with CT, and you can diagnose hydrocephalus by measuring the third ventricle. This as a B mode. And as you see here, this is the anterior horn of lateral ventricle, and this is very clear anterior horn of the lateral ventricle. You can measure it very easy, and it's correlated with the CT. So ventricular system is very important for diagnosis of hydrocephalus in a lot of neurocritical care disorder, and can help a lot. And number 3, you need to look for the midline shift. And the midline shift is very important for us in the ICU for a lot of diseases and for follow-up on neurocritical care. As you see here, this is the third ventricle, which is a tubular-like structure with anechoic CSF and hyperechoic wall with the great landmark, which is the calcific penile body posteriorly. And this is the third ventricle here, this is the third ventricle here. And as you see very clearly, third ventricle is the midline structure. And I can use this very important information that the third ventricle is the midline structure, and I can assess the midline shift very easy by measuring the distance from the bone to the third ventricle on the left side, and measure the distance from the bone to the third ventricle on the right side. And by this simple equation, I can measure the midline shift by subtracting the small distance from the long distance and divided by 2, and the midline shift will be towards the short distance. And this is validated in several studies against CT, and it can be used very easy. As you see here, you can assess the midline shift. So, brain ultrasound as B mode. First, B mode is just looking for the brain tissue, the echogenicity of different structure in the brain, and the echogenicity of abnormal lesion like hemorrhage. What is brain ultrasound as B mode? It is looking for the brain by the B mode to assess for abnormal echogenicity, which is the hemorrhage elsewhere in the brain, and looking for the ventricular system if there is any dilatation or increase of diameter as a diagnosis of hydrocephalus, and any intraventricular bleed, and you can assess the midline shift. And there is other several factors, but this is well-known application now for brain ultrasound as a B mode. You are exploring the brain tissue, and as you see, it's only one window, which is a temporal window above the zygoma in front of the ear in this thin temporal bone, and only one maneuver, which is the tilting up. It is a lot simpler than echocardiography. Okay, we now will go to second application of the brain ultrasound as a Doppler. Now we are searching not for a lesion in the brain or the ventricle, but we are looking for the blood flow of the brain. We are looking for the direction of the blood flow and the velocity of the flow in the basal cerebral arteries. How to do it? Very simply, the same way. But here we have several windows. Today we'll talk about two famous windows, through which you can explore all the circle of Wills, which is the temporal and subcostal. First, the temporal window, the same like brain B mode. You will put in the temporal bone above the zygoma in front of the ear, phase array probe, which is the echo probe, 2 megahertz. And some machine now, most of the machine now have TCD as a software. You can select it, and the depth is 13 to 15 to see the other part of the skull, and you will adjust the focus in the midline. And as you see here, my probe in the famous temporal window in the left side, and as you see here, the ultrasound beam is directed in this direction. You see very easy, you can explore the middle cerebral artery, which is moving towards the ultrasound beam, and the anterior cerebral artery. And if you tilt downward, only just a little downward tilt, you can explore the 2 posterior cerebral artery, and you can complete the circle of Wills here. But now we are not using the rule of B mode, which is depend on the reflected ultrasound, and according to the reflected ultrasound will be the echogenicity in the screen, and this reflected ultrasound depend on the density of reflected tissue and lesion. Now we are using another rule, which is the Doppler rule, and we need to know about Doppler equation, because through this equation, this intelligent machine can measure the velocity. But I am sure you are doctor, you are all doctor because you hate this type of formula. But very simply, I will not discuss in details, but the aim of ultrasound, brain ultrasound as a Doppler mode is to measure the velocity and direction of the flow. Velocity and direction of the flow. Velocity by Doppler equation, as you see in this formula, this C, which is the velocity of the ultrasound in the blood, which is a fixed number, 1,540 meter per second, and this F, which is the frequency of the probe, which is also the fixed number, 2 megahertz, and frequency shift, but it's also depend on the flow of the red blood cell. So you have three factors here. You can do nothing for these three factors. It is don't rely on you as a sonographer, but the last factor here, which is the cosine of the angle of insonation, this is rely on you, and this you should do it in proper way. You need to adjust the angle of the probe to get in parallel to the blood flow as much as you can. And as you will see now by the brain ultrasound, the TCCD, you can see the blood vessels and you can put the pulsed wave in the direction almost parallel to the blood flow. It's easy business for the TCCD, not for TCD, which is old machine. But you need, if you don't remember this formula, which is a Doppler equation to measure the velocity of blood flow, you need to know the imaging rule of Doppler, which say any blood flow towards my probe here in the temporal area will appear in red, and in spectral Doppler will appear above the baseline. As you see here, this is the systolic velocity and this is the diastolic velocity. And any blood flow away from my probe here will appear in blue, and the spectral Doppler will appear below the baseline. This is the imaging rule, and you need to know that as a sonographer. And as I said to you, please don't proceed in brain ultrasound without seeing this beauty butterfly, which is the midbrain. Don't proceed in brain ultrasound B mode or Doppler without seeing this midbrain through this temporal window. Because as you see here, the midbrain, you will see all the circle of wheels all around in front of the midbrain. As you see here, the posterior cerebral artery circulating around the midbrain, in front middle cerebral artery going in this direction, anterior cerebral artery going in this direction. So it's very important to localize midbrain before you proceeding to complete your examination. And fortunately, as you see here, this is the skull base, and we are assessing the basal cerebral arteries. And as you see here, fortunately, this is the midbrain, and in front of the midbrain, here is the cavernous sinus, and this is the internal carotid coming from the cavernous sinus, will give the middle cerebral artery and the anterior cerebral artery, and here the basal artery will give two posterior cerebral artery. This is the circle of Wills, and as you see here, all are accessible. Most of the circle of Wills are accessible from the temporal window here. You can see this middle cerebral artery and this anterior cerebral artery and this posterior cerebral artery very clearly. You compare this CT angio with this great brain ultrasound as a Doppler. You can see here is my probe in the right temporal area, and I explore the midbrain here, which is the butterfly area with wing looking anteriorly, and you see the posterior cerebral artery on the right side curving around the midbrain, and the middle cerebral artery going towards my probe, so appear in red, and anterior cerebral artery in the right side going away from the probe appear in blue. But the anterior cerebral artery of the right side, of the left side here, because here I'm right side, here left side, going towards my probe to meet the other anterior cerebral artery, so appear in red. So this is a circle of Wells, and this is a circle of Wells. And as you see, the clue here is the midbrain. Once you get the midbrain, everything is very clear. You see here, this is the internal carotid artery giving anterior and posterior and the middle cerebral artery. Here is the middle cerebral artery giving anterior and middle cerebral artery. Here is middle cerebral artery, anterior cerebral artery. But to explore the vertebral artery and the basilar artery will be very difficult to get it from here, but very easy to get it from here, subcostal. This is a CT angio, but I make it upside down. This is a suboccipital window, and I put the probe here. As you see, you will see this two vertebral artery and the basilar artery, V-shaped, inverted V-shaped, and the basilar artery very clear appear in the here subcostal view. This is the vertebral artery upside down and giving to basilar artery in this V-shaped. And as you see, it's only one window, one probe, one frequency, and one maneuver, which is the tilting. You can know a lot. You can diagnose very important disease and lesion in the intensive care. And moreover, we can use this brain ultrasound to assess the conscious level in patient before weaning, and a lot of other indication. But I need to be very simple in these lectures, and I need to talk about very apparent areas. And thank you a lot for your appreciated listening, and I would be happy to explore any point anyone need to. So thank you a lot. Thank you, Dr. Walid.
Thanks very much, Dr. Walid Chebel. Kindly put your questions in Q&A sections. So I'm stopping your presentation now, Dr. Walid, and we'll put the poll for documentation of attendance as usual. So you can start voting now. So Dr. Walid, if you give us like a quick idea about, until we get some questions here in the section, if you give us a quick idea of how beneficial the ultrasound could be in subarachnoid hemorrhage in a patient that is possibly developing a cerebral vasospasm, instead of going to CT brain every 12 hours and sometimes more frequent. That's one of the common patients we see in our practice in critical care, surgical intensive care, or trauma ICU. A lot of patients coming with cerebral hemorrhage, either medical or surgical bleeds. So is there any difference between both of them in the term of cerebral vasospasm, and what's the role of ultrasound, if any? Thank you.
Great, Dr. Walid, great questions. And this will reveal very important point. And we face it a lot because subarachnoid hemorrhage is not only with medical people with rupture aneurysm. It is very common with traumatic brain injury. You can see reaching almost to 50%, 40 to 50% of the people has this vasospasm. And as you just mentioned, Dr. Walid, very clearly, you cannot send your patient to CT every day to check for vasospasm and to check for the complicated hydrocephalus. And it's very annoying for the patient, and a lot of radiation. And how can our patient in ICU, this trauma, brain trauma patient and neurocritical care, low stroke, this probably are sedated. Well sedated. We don't have even proper clinical assessment for the patient. But if you put the phaser probe in the temporal area and measure the velocity and document this velocity, and this is already evidence-based, score evidence 2A. Score 2A in American Stroke Association and the American Heart Association. In the last guideline, the assessment of the vasospasm by TCCD, and now we are not talking. There's very little difference, very important to know. There is TCD and TCCD. What we are talking now is the brain ultrasound, is TCCD. We see the blood vessels, as you just saw. We see and we can put the pulsed wave. But the TCD, which is a blind technique, it's all technique, and we are not talking about that. This indication, one of the most important indication, and can help a lot. And there's other indication, Dr. Walid. I faced several patients in the last period. It's very important to check the conscious level before extubation and weaning. Is it right, Dr. Walid?
Yes, correct.
And your patient on sedation, and you may be misinterpreting the conscious level. But if you put the brain ultrasound and you saw too much velocity, you can send your patient to CT before going to extubate. And I faced 2 patients like that, especially in the era of the COVID. And there is abnormal brain Doppler, very abnormal, very distressing. I send the patient to the CT, and there is severe brain edema. This is a lot of indication, really. But as you saw, it's now evidence-based, and the evidence is coming. This review I mentioned in the Intensive Care Journal, April 2019, believe me, the time after this review, it's not before this review. In these reviews, they are talking now about certification. There is basic certification and the advanced certification. It's really different. But
it's growing. It's growing very quickly.
It's
growing very quickly. So here you mentioned these 2 patients that had very high velocity. So I think, correct me if I'm wrong here, if you detect very high velocity on the middle cerebral artery or one of the cerebral arteries, do you do the Lengard ratio and go to the carotid first?
Excellent.
Or do you have a look on the blood pressure to see? Because I believe if the patient is have some pain and his blood pressure is 180, and he was normal velocity on the middle cerebral artery before, now it will be high. So what do you compare with? Is it the arterial line tracing, or is it the Lengard ratio on the carotid? What is your baseline?
Very simply, if there is stenosis or spasm local in the middle cerebral artery or anterior cerebral artery, that means the velocity will increase in this artery. But as you mentioned, if the patient has hyperdynamic circulation, if the patient under triple H therapy with hemodilution, hypervolemia, and hypertension, this patient will have high velocity all over. As you mentioned, now we used to do Lengard equation. If I saw too much velocity in the mid-cerebral artery, I will assess the velocity in the feeding artery, which is the internal carotid. If it is generalized process like hyperdynamic circulation, it will increase in both. But if the velocity in the mid-cerebral artery more than the internal carotid artery by 3 factors, it is spasm, it's mild spasm. If it's more than internal carotid artery by 6-fold, that means severe spasm. And also assessing the carotid is very superficial, and you can assess by a linear probe. And this, believe me, this maneuver is too much easier than the echo. I know you are expert in echo, Dr. Walid, and you can mention how many window for the echo, how many tilting and rotation and leaning, how many. Like we are talking about 1 window, 1 tilt. It's very simple maneuver, but you should try it. And already the echo is the echo probe, and it's not.
Surprisingly, Dr. Walid, I was attending one of the virtual webinars from Canada yesterday with a new Canadian team in neonatal echocardiography, and they are using the phased array and the linear probe as well to diagnose a lot of transcranial pathologies, because the fontanelle is open, so their window with ultrasound is almost as sensitive as the MRI brain. So they did a lot.
Believe me or not,
it's
the standard in neonates. The standard is the brain ultrasound. They compare the MRI by brain ultrasound because this is the standard. Believe me or not.
Yeah. So I think it's coming in the horizon very quickly. This is all new modalities. There is a lot of workshops now happening in neonates, in pediatrics, in infants, and even intrauterine. So I have a question here. Transcranial Doppler have any role in sickle cell disease and fat embolization, if I got the question right from Raghib al-Misiri. So he's asking about SCD. I believe this is sickle cell disease and fat embolization. Do we have any rule from ultrasound on the brain?
It's very nice questions. طبعا sickle cell disease, it is a very strong recommendation to follow the sickle cell disease by brain ultrasound, because if you find too much velocity in the midcerebral artery, this is indication for blood exchange, and you need to keep always the hemoglobin S below 30%. And this is hard fact. It's grade 1 evidence. In sickle cell disease, it is a must. You should do transcranial Doppler. In fat embolization, the TCD is the only imaging which can reveal the microemboli. No other imaging modality can assess and can look for the microemboli. And the fat embolization is a sort of this microemboli and appear very clear as high intensity signal, because imagine in this for a second. Brain is 2% of the body weight and receive 20% of the stroke volume. The best flow ever in the brain is the brain circulation, is the middle cerebral artery, mainly middle cerebral artery. The flow in the middle cerebral artery is the best flow ever in the body. So you can see through this very clear flow and very huge flow, you can see microemboli. Very easy. And if you see it once, you will not forget. And there is 5 case report about diagnosis of fat embolization of the femur fracture by looking for the TCD. Very nice questions, really. Very nice.
Perfect. Question. Perfect. So is it a tool to diagnose brain lesions or just for follow-up? He means the diagnosed lesion according to guidelines. A question by Muhammad Al-Aidi.
There is evidence-based you can diagnose brain hemorrhage. As you saw, there is, I saw in 6 cases of 7 cases of brain hemorrhage, you will see hyperechoic lesion. There is a study done on 151 patients. There is very good correlation between the brain ultrasound and the CT. Almost sensitivity is 95, specificity is 95 to diagnose brain hemorrhage by brain ultrasound. But you should have, the only obstacle is the window, because temporal window may be an obstacle in 12% of patients. So you should have a window to be sure you are exploring the brain tissue and you are diagnosed brain hemorrhage. As regard brain hemorrhage, it's evidence-based 2P, evidence-based 2P to diagnose brain hemorrhage, and you can diagnose midline shift by this simple equation, and this is validated against CT. But if the lesion, brain tumor, I don't hear about brain tumor. We are talking about hemorrhage and follow-up hemorrhage and midline shift and hydrocephalus. I am talking about 3 points. This is the most important, and there is a study about that. But the problem, no new studies. These studies all were old, and despite the good sensitivity and specificity, something surprising, they are not doing a large one. We need, with Dr. Walid, inshallah, will try to do it in Mahad, inshallah. We should do a big one about that, multi-center.
So that takes us to the next question. Yeah, that takes us to the next question about how to measure the ICP by ultrasound. I'm sure he's talking about optic nerve, not Doppler or anything else. So what's your input in that regards by Dr. Negm and Dr. Muhammad Muqbil? Both are talking about ICP measurement.
Okay, ICP measurement, okay. The people who talk about ICP measurement, really, there is 2 groups here. I think Bellner and Zwiffel, and there is some people talk about, they were very eager. We can do it. We can measure ICP through the brain ultrasound. And the theory here was if the increased intracranial pressure will press on the venous system and small arteries, this will impede the blood flow in diastole compared to systole. So what's called the pulsatility index will increase. And they mentioned BI is very sensitive to diagnose increased cranial pressure. But unfortunately, the coming study after that, they disregard this issue about the role of the BI in the diagnosis of increased cranial pressure. You know, طبعا they are talking about the non-invasive against the gold standard, which is the invasive. So there is still controversial point, but it's very important point. Why there is misleading point? Why BI? Some people say the BI is very important to diagnose increased cranial pressure, and some people say it's not. This is because there is other factor increasing the BI, like heart rate, like pulse pressure, like very important peripheral vascular resistance, like blood pressure. And they mention 4 to 5 factors can affect the BI. So in this great article, if you read it with all subdivision, this article in the Intensive Care Journal, April 2019, he mentioned very important. You may rely on the BI in the assessment, because BI is very easy to measure. You may rely on BI in diagnosing increased cranial pressure if you have pulse pressure less than 60 and mean pressure normal and heart rate is not bradycardic. Yani with this precaution, and with CO2 is normal. If you have this 4 parameters and you can get this parameter in ICU, you can rely on BI. This is number 1. Number 2, Professor Roba, genius professor, really had a lot of articles and publication for brain ultrasound. It's genius. She started to talk about why we are using only one parameter like optic nerve sheath diameter in diagnosis increased cranial pressure. She used another parameter. She used BI with optic nerve sheath diameter, and at the same time, she used the big velocity of the venous sinuses, the straight sinuses. And she found the area under the curve, which is due to sensitivity and specificity, was more when using more than one parameter. And this is what I'm talking about. We are talking about brain ultrasound density. You are put the phase array probe, measure the BI, measure the optic nerve sheath diameter, look for the midline shift, look for the hemorrhage. This is 4 factors, and use these 4 factors will increase your sensitivity. I'm sure if you do score like Marshall score with these 4 factors, I'm sure if you compare the increased cranial pressure with the gold standard, which is invasive, I am sure you will find a very good sensitivity and specificity. This is as regard, I'm sure the people who ask about that, they know about the controversy. But now I hope I clarify the point.
Okay, just for our colleagues that may be not familiar with what is PI and RI. The PI is pulsatility index and RI is resistivity index, and this is part of any vascular Doppler examination. When you map all the tracing, so you get the pulsatility and resistivity index. You use pulsatility index in certain occasions and resistivity index in another occasions, but this is tools like the cardiac output assessment in hemodynamics, something like that, if it is the same similarity. So if any of our consultant speakers, attendees has any questions, please let me know, or you can straightforward open your mic and ask your question. Until that happens, we have a couple of questions asking about ischemic stroke, Dr. Walid. Is there any role of ultrasound to diagnose ischemic stroke, particularly if the window time has passed and we don't have a facility for a CT? Plus minus follow up before and after RTPA? Is there any role for ultrasound?
Yes. This is validated. And there is a rule for that. As you see in this lecture, the flow in the mid-cerebral artery and the anterior cerebral artery, sensitivity of seeing the obstructed flow in the middle cerebral artery due to embolus or thrombosis, it's high. Compared to CT angio, it's almost 90% in middle cerebral artery. And it's very high sensitivity in the diagnosis of stroke. And moreover, you can follow for recanalization. you will not send your patient to CT angio several times per day, but you can assess the recanalization every couple of hours. You can do it. You can do it, and as early if there is early recanalization, this is good prognosis, and you can talk with the relative about the prognosis if you got this early recanalization. And moreover, the complication of stroke, you're afraid from the midline shift with the malignant mid-cerebral artery. You will follow the midline shift every day, okay? And hemorrhagic transformation. Good. If you can very easily detect hemorrhagic transformation in the. It is easy, but you need to do it. You need to start to do it because. Yes.
A question from Dr. Negm again. If you detect the velocity in the internal carotid artery and the velocity in ICV, I don't know, is it a cerebral vein or something? Can you detect blood flow in brain to consider the ICP? I don't know if I got his question right.
What is done here? Very important formula. The formula validated against the gold standard, which is invasive. This formula said simply cerebral perfusion pressure equal mean arterial pressure multiplied by diastolic flow velocity over mean flow velocity plus 14. There is a study done for that, and this formula was validated against the gold standard. But they rely on TCD because they did a lot of TCD. You will connect the machine, and she can be monitoring for 30 minutes, 1 hour, and it is continuous monitoring, spectral monitoring. And with this machine, but I used to do it in ICU because for this patient, which has increased the blood pressure, I can do it frequently by TCCD, and it's very easy, as Dr. Walid said. The machine, you will put the pulsed wave Doppler in the middle cerebral artery. The machine will measure all this for you. The machine will measure the mean velocity, the diastolic velocity, everything the machine will do. And if you have arterial line, you have the mean arterial pressure. And you can do this formula, because if you measure the cerebral perfusion pressure, very easy with mean arterial pressure, the difference will be intracranial pressure. This formula is validated. This formula is validated. But if you measure the venous and arterial, it's long pass. This is a recommended formula. This is a recommended formula.
Perfect. One of the interesting publications a few years ago as well in anesthetics, you asked me about the implications in anesthesia. Cerebral circulation is of one of most interesting concerns intraoperatively, particularly with hypotensive anesthesia. What is the lower limit possible for the blood pressure and the cerebral perfusion pressure? So one of the nice publications, it was a few years back, I read it maybe 3 or 4 years back. So they put the Doppler of the echo probe here, and they fixed that with a bandage. And they kept monitoring the cerebral blood flow with different blood pressures, and they see when is like cerebral blood flow, and they measure the pulsatility index and diastolic flow, and they see below 30 or 40, and they measure the mean pressure, and they see and they found that they did a lot of patients without intervention with the hemodynamics because diastolic flow was satisfactory even with a lower mean arterial blood pressure. I think the only thing against this publication which made me a bit difficult to believe it is how to, if the surgery is 3-4 hours, how you keep this probe position fixed in the window with the gel in place, with everything right for 3 hours.
In this situation, he will use not the TCCD, he will use the TCD because there is helmet. They can fix The TCD.
No, this is not what was mentioned in the article. It was the phased array
TCCD
probe
is
of
very
an
strange, very strange.
yes.
Very
Yeah,
strange.
Believe me, I'll
Very
send you this
strange.
article if I find it again. But
Very
I'll send it to you. It's a very interesting one.
Yeah.
So thanks very much, Dr. Walid. I think we have no more questions here, and like we do really appreciate your presence with us tonight and your effort. And it's good to know and to publish that Dr. Walid Shibl is teaching a brain ultrasound course coming soon under Saving Lives Academy, and will put all details on the website soon, inshallah. So for whoever is interested, there is a lot of potential publications for the masters and MDs, and a lot. It's a very good area for new research. If you're looking for a genuine and legitimate research questions, there is a lot of open areas for research in the moment and for the last few years about transcranial ultrasound implications in anesthesia and critical care. So thanks very much, Dr. Walid, again and again, and see you again soon, inshallah, with the launching of the new course. Thanks a million. And this will take me to my lecture. And sorry. Okay. So my name is Walid Al-Habashi, and I'm Anaesthesia and Critical Care Senior Registrar in the Mater University Hospital. I think maybe most of you are familiar with me here, but I have my own personal interest in critical care, echo, critical care ultrasound, and I'm doing anesthesia exam preparation courses for the last 5 years. So please bear with me for this coming 30 minutes to talk about one of the most interesting topics. I presented maybe 4 years back in the channel, but this is a new dress for the same topic. So before I start my talk, I would like really to thank everyone here that asked about me and prayed for me. I do really appreciate your kind psychological support and your prayers as well, which is the main reason for me being between you here today. Yesterday I was in a very bad shape, so forgive my non-shaving beard. Non-shaved beard and my look. It was really hard to make the time to prepare the lecture and appear as usual. Tonight I'm speaking about one of the commonest topics that meets you in real life in anesthesia and subsequently would be in the exams. COPD patients. You may find it as a sole case, short case, or with other comorbidities. So if you can really understand what's happening, you can have a lot to write about this case. So first of all, I don't have any conflict of interest. Objectives of this lecture will go quickly through the definition and pathophysiology of COPD and what's the difference between COPD and COED. Is there any difference between them? What are the anesthesia concerns with this patient? How to plan and conduct a good plan of balanced anesthesia for COPD patients? What are the anesthesia-related problems for those patients? How to prevent them and how to diagnose them quickly? And I will give you a good example of one of the most common procedures done nowadays for these patients is one. It's called Chartes assessment. What's the Chartes assessment? This is an assessment procedure done intraoperative under single lumen tube anesthesia with bronchoscopy, flexible bronchoscopy. It's a preparatory session for an endobronchial valve treatment for emphysema. So I'll explain all what's happening in the last slide of this presentation. Then we'll open a discussion about this lecture. So what is the name is properly COAD, chronic obstructive airway disease, or chronic obstructive pulmonary disease. The old name was chronic obstructive airway disease, looking at it starts in the small airways, but it had changed quickly to chronic obstructive pulmonary disease, or COPD, because it has two main components. One is alveolar, which is emphysema, or one is parenchymal, which is emphysema, and it is resulting from the airway disease. So it's not only the airways affected. So it's COPD is the commonest name and the most recent name. So that's why you may find COED in some books, particularly the English books. So COPD is a very common, extremely common respiratory disease because smoking is very common. Severe COPD is particular severe COPD carries any type of surgery, even simple surgery, have a 2-year mortality around 47%. So after 2 years, you get almost half your patients died if they are not assessed and treated properly. That's why this makes this lecture very important and a topic in the exams. So your understanding of this makes a lot of difference. So significant risk of post-operative morbidity and especially pulmonary complications are very common as well. So if not died, he may suffer some pulmonary complications. However, with risk identification, risk stratification, and preoperative optimization and proper anesthetic planning, these risks for post-operative, particularly the pulmonary complications, can be reduced even in patients with severe disease. So you can decrease the risk even with severe diseases. So what is the planned surgery? So let's have a look here first on the pathophysiology. So what's the definition of COPD or CAD? It's a progressive inflammatory disease. So it's not static, it's progressive in nature of the lung parenchyma, characterized by airflow limitation that's not fully reversible. So it's an airflow limitation with partial or no reversibility, and is often accompanied and complicated by significant systemic manifestations and comorbidities. Components of this disease are mainly two components. One is the obstructive component, one is the parenchymal component, which is emphysema. So small airway obstruction or this restricted airway or resistance of the airway, the small airways increase, causes a dynamic hyperinflation. Dynamic hyperinflation allows VQ mismatch. What is the VQ mismatch? It's the mismatch between the ventilation and perfusion. Because of poor ventilation, because of air is trapped, it does not leak out, so there is no proper gas exchange. And with the dynamic hyperinflation of the airways, it will squeeze the vessels or the vasculature between the alveoli, so that will cause, again, another type of ventilation perfusion mismatch. So what is the VQ mismatch happening in the COPD patients? Is it dead space or is it shunt? It's actually a mix of both. Dead space, by definition, is the area that is not dead, means dead like a dead cat, with no flow. There's no blood flow. So how this happens in the COPD? Because air trapping causes squeeze of the vasculatures or the blood supply between the increasing size the alveoli. Okay, so the distension of the alveoli because of air trapping will squeeze certain areas. With this squeeze, there is no blood flow. So these alveoli are highly ventilated because there is over distension, but they are not perfused. So this is actually a dead space. Okay, alternating with another alveoli that are poorly ventilated, okay, because very squeezed airways, these alveoli are not ventilated. So if there's alveoli that's not ventilated, but blood supply is passing good in between, so that's a shunt. So the bridging of blood without oxygenation. So actually the COPD is a mix of shunt and dead space, both in different lung segments. Okay, that's what creates the VQ mismatch. This hypoxemia and hypercapnia resulting from this dead space and shunt will cause what we call cor pulmonale with time. What is cor pulmonale? So we'll go to the definition of cor pulmonale, but it is kind of significant increase in the pulmonary artery pressure causing right-sided heart failure or right-sided high pressures and heart failure. There is another sequelae or consequences of COPD, like respiratory, skeletal muscles wasting, muscle wasting, weight loss, and cardiovascular, as we said, like the core pulmonary. So these are considered extra pulmonary complications and manifestations, and you need to look for that. So now for my junior colleagues, I always advise classify or die and plan ahead if you're preparing for your exam. For any patient at all, you are putting under anesthesia, I need you to think in this general approach. What are the considerations of this patient? How you do preoperative assessment? And what's your anesthetic plan and how you conduct your plan? So this is how you want to write about any patient you are putting asleep. So consideration, pathology, if this patient on any medications for this pathology, if there is any drug-drug interaction between these medications and your drugs, did this patient has any anesthesia troubles before, and will this implement on your plan? What is the surgery he is undergoing today? Did he do any previous surgeries that may interrupt with your anesthetic plans? Like did he have any lung transplant? Does he have any single lung? Does he have any tumors? Does he have any previous surgeries he got before? And is there any conflict between these different elements or considerations and each other? This is like, we'll discuss that in details in our patient tonight as an example for that. Then the preoperative assessment, again, the history related to your pathology, like COPD today, ample history, you can say anesthetic and allergies, medications. Sorry for that. I'm sorry, pardon me. Sorry for interruption. So the ample history, the drug-related, sorry, we stopped here. Past medical and post-surgical history, the last meal, and E is events related to this admission. Is it a trauma patient or whatever? Drug-related history, so if this patient had any drugs or is he allergic to any medications or something like that, or he's on any medications, again, I need to know about maybe marijuana, maybe whatever the drugs he's on may affect my induction plans. Then examination, again, the routine examinations, airway assessment, okay, and then respiratory, cardiovascular, quick abdominal and lower limb edema is one of the routine exams. Then investigations, what is investigations you are putting for in general and for different procedures. Then if you need to consult anyone or to do referrals to optimize the patient before admission to ICU, to anesthesia. So this is the preoperative assessment. Then the anesthesia plan now, I am planning this anesthesia plan in the pre-op assessment clinic. So this is not what I'm conducting. I'm still planning here. So am I going to put this patient under general anesthesia or regional anesthesia? Is it possible to do the regional if it is the best? Airway versus aspiration, mother versus fetus, if any conflict like that in general. And then what you optimize, the pathology, the medications, what medications you need to give, what medication you need to stop before surgery. And any anesthesia-related issues needs to be optimized before coming to theaters. And options, is it general, regional, mix of both, whatever. Then the day of surgery, this is now the anesthesia conduct, and there is still a preoperative element of the anesthesia conduct. So this is a pre-op assessment and planning, okay? And this is conduct of anesthesia. Consent, pre-medications given in the day of surgery, blood cross matched, the ICU or high dependency unit bed or step down unit bed, the room setup, the patient position, the lines, the medications. Then you start here towards the end is the induction. So you have seen here a lot of things to write in your exam before you put your patient asleep. This is the induction, which is like if you reach this degree, you got maybe 70% of your answer already. Maintenance, fluid management, monitor, emergence. This is the recovery, emergence and recovery for patient, and where you will disposition your patient to where and what is your plan on this position. This is a general map if you're thinking about any patient. So let's tailor this map now on our COPD patients. So what are the considerations? You need to do to know what is the pathology. I spoke about VQ mismatch. This VQ mismatch is my patient is hypoxemic respiratory failure or hypercapnic respiratory failure or mix of both. Anyway, you need to know that hypoxic pulmonary vasoconstriction may induce acute right-sided heart failure, and that's sometimes very hard to treat. So here the prevention is better than cure. So make all the effort to maintain oxygenation in acceptable level. So what is the acceptable level? That's tailored according to your patient. So it's not a bad idea when you're starting to induce your patient to put an arterial line when the patient is on room air and know what's his baseline PO2 and PaCO2 on room air, and don't use a lot of oxygen, like 100% oxygen. You can pre-oxygenate with 80 or 85% oxygen just to prevent absorption atelectasis as long as you're achieving a good PO2. So as I said, hypoxia causes hypoxemic pulmonary vasoconstriction, and maybe if this happened as acute, it might precipitate an acute right heart failure, and that's sometimes very hard to treat. How you treat it if it happened? The best pulmonary vasodilator is oxygen, and if not, you can treat with other medications, but the best pulmonary vasodilator is oxygen, so oxygenate your patient well. And don't be focused on the myth of that if you give your patient oxygen or more oxygen, you will depress his respiratory drive and patient will be apneic. Yes, he will be apneic because you're paralyzing him in a minute or two because you're putting an endotracheal tube. So that is a concern after you start to wake him up, not during the induction of anesthesia, okay? So again, cor pulmonale is defined as an enlargement and right heart failure due to pulmonary vasoconstriction as a cause of severe pulmonary vasoconstriction. Okay, so that causes right-sided high pressures. Right ventricle is not used to this high pressure because it is not a systemic circulation, because it does not have the 3 layers of muscles of the left ventricle. It does not have this big muscle mass. So you have to avoid increase of the pressure. So you have to avoid any increase in the pulmonary vascular resistance and pulmonary arterial pressure. Okay. So pulmonary hypertension is one of the concerns again. If it is there, what is the pulmonary artery pressure? If you can find out that from an echo report or anything like that, or a right heart catheterization, it depends on his stage of COPD, and we'll discuss that in a minute. Usually because of their hypoxemia, there is a polycythemia. Polycythemia render them a hypercoagulable state. There are high instance of DVT, and hypercoagulable state may cause low cardiac output in case of low flow. So you need to optimize your patient hydration. Another pathology is the bulla, and if the patient has bulla, you need to figure out that there is a bulla before you put this patient asleep. Otherwise, if it ruptures, it will end up by a pneumothorax, and if it's bilateral, you may end up by tension bilateral pneumothorax, and patient will die on table. So you need to know that this is a concern with a COPD patient, and your level of carboxyhemoglobin as well. Plus other comorbidities, because this patient, if the cause of the COPD, which is very common, is the smoking, this is usually affecting more than one organ, like cerebrovascular disease, or he has a cerebrovascular accident before, peripheral vascular disease, coronary artery disease. So if this patient has other comorbidities because of the same etiology of COPD, which is the smoking. Okay, what is this patient medications? Is he compliant with his medications or not? Is he on steroids or not? What is the current medications? And what is the surgery? Is it a simple surgery that can be done under local or limb regional anesthesia, or this is something very serious like shared airway with a lot of manipulations, like the Chartres assessment for endobronchial valve treatment for emphysema? So 2 extremes of surgeries could be presented to you. So you need to importantly know and discuss with the surgeon what is the surgery. And is there any conflict between this surgery and your anesthetic practice? I mean the conflict here, like if you're planning for knee surgery that will take 2.5 or 3 hours, and you are planning to put an epidural for this one, which is a fantastic plan, but actually your patient is unable to lie flat for a couple of hours, or he gets very distressed after 30 minutes. So you need to discover that before you're sticking an epidural needle in his back and put your plans, and then you discover or you find out this patient actually cannot tolerate that. Okay. So this is what I mean by conflicts. So preoperative assessment for this patient history, you need to find out how many exacerbations this patient got in the last few months, or he's never been admitted in a hospital or never had an exacerbation, or he is like having chest infection every 1 or 2 weeks, how many hospital admissions, and previous requirement for invasive mechanical ventilation or non-invasive mechanical ventilation. What's his smoking history? Is he still smoking? That's very bad. This is one of the worst outcomes. Try to stop or to make your patient stop smoking as much as you can and as quick, and try to space at least 8 weeks between your cessation of smoking of the patient and the surgery, because this carries the best outcome. So again, you need to stop his smoking for like 8 weeks before the surgery. That is the golden number. And so if the patient has active sputum, this will trigger the bill of active infection. So do CRP, white cell count. If the CRP is high, white cell count is high, and the patient has green sputum, that's an active infection. Please don't go to theater with this patient unless it's really emergency procedure. Okay, so this patient has an active chest infection, which carries the highest mortality here. So what are the other morbidities? Like if there is any cor pulmonale, any heart failure, and it needs to be treated before that, you need to optimize his cor pulmonale and heart failure before you go ahead with the surgery. Okay, nutrition. If the patient is a smoker and COPD, I believe it is not uncommon to find he's not taking care of his diet well and maybe malnourished. So you have again to think about this one before you put him asleep. The body habitus during your examination is interestingly in one of the extremes. Either he's cachectic, malnourished, because he is a chronic smoker, he's smoking like 40, 50 a day. So the anorexia and nausea associated with this one prevents him from eating well, or he is on steroids and repeated chest infections and repeated steroids will be overweight. So you usually see either very cachectic patient or very obese patient, the COPDs. Okay, so chest examination, you cannot put a patient asleep without examining his chest very well. And when you examine, please do front and back and be very careful with your examination. What you need to auscultate is a bronchospasm. So this is an active bronchospasm. This patient needs an active management, escalating his bronchodilators and his steroids. So refer him to the pulmonologist to control that before you put him asleep. And crepitations, and that means a chest infection. Lung ultrasound is of good help in this occasion. You can diagnose active pneumonias and active atelectasis, and there is no diagnosis of asthma in the Blue protocol except with diagnosis of exclusion. So if it's just bronchospasm, it's your stethoscope rather than the ultrasound. Again, examine the heart well, heart and its related organs and structures. So look at the jugular veins, look at the tender congested liver, but look at the lower limb edema. Then investigations to support your theory if this patient is okay to go ahead, or he has a chest infection, like if you find white cell count, as I said, high. ABGs, as I mentioned, it's not a bad idea for any like moderate surgery or significant surgery to do an arterial blood gases at baseline room air before you put anything. So avoid giving any sedation before your arterial line. Be generous with local anesthetics to put an arterial line. And CO2 more than 5.9 kilopascals, and you can convert that into millimeters mercury by multiplying by 7.5, and PO2 less than 7.9 kilopascals on room air are both associated with the worst prognosis. So your 5.9 and 7.9 more and less is your golden numbers here. So X-ray is very important for any patient with active COPD or he's still smoking. So it diagnoses infection, or if this infection with chronic irritation of his lung parenchyma, change it into malignancy, and to rule out any bully, as I said, because it will imply on my ventilation plans. ECG, you're looking for any arrhythmias. Atrial fibrillation is not uncommon with those kind of patients, and right ventricular hypertrophy or and strain pattern. If you're suspicious with your ECG pattern, so okay, go ahead for an echocardiography, particularly if you have any other comorbidities. Pulmonary function testing, are we doing that for all COPD patients? No, this depends on the history and the physical tolerance of the patient. So you can ask him how many minutes you can walk on a flat surface, how many flights of stairs, and if he's getting shortness of breathing quickly enough, so that will ring the bell and ask for a pulmonary function test. And as you see here, this is the normal pattern, and this is the COPD pattern with airflow limitation. This is the residual volume. This is the normal tidal volume, and this is the total lung capacity from here to here. Okay, so this is residual volume. So you cannot expirate, or you cannot expire this amount of air, if you remember this from the physiology. So this volume cannot go out until here. And this is the this is the normal tidal breath, and this is the total lung capacity from here to here. So this is a flow volume curves. So this is the volume on the x-axis, and this is the flow on the y-axis. Okay, so we'll discuss what are the gold criteria in the next slide. But if you have this flow pattern and you feel that there is a reversible element in this patient, and there is always a reversible element, you can look at what is the post-bronchodilator flow volume curve appearance, and you can refer that to the pulmonologist. And if there is any suspicion about core pulmonary and heart failure, you can refer him again to the cardiologist as well. So what is the goal? The goal is the global initiative for chronic obstructive lung disease. Okay, so this is the GOLD criteria. So your staging the patient is 1, 2, 3, 4 stages. All the 4 stages are the same from FEV1 divided by FVC. FEV1 is a forced expiratory volume in the first second. FVC is a forced vital capacity. If you divide the first by second and you get less than 70%, you're by definition have a COPD. But what is degree? So that is classified according to the forced expiratory volume in the first second. If it is more than 80%, you are a mild. Okay, if you're 50 to 79%, that's your grade 2 or gold grade 2. 30 to 49%, you are gold 3, and less than 30%, you are gold 4. If you are lying in this stage, gold 3 and gold 4, your patient is lying in this stage, it carries very high mortality and morbidity, needs optimization, possible need for ICU bed, if not HDU bed, and he may need postoperative mechanical ventilation. So you need to know and judge your patient well according to these criteria. You need to be aware of them. As I said, so here, the conflict, GA versus regional anesthesia. So some people think that regional anesthesia is the gold standard for COPD patient all the time, but I can show you this publication, 100% incident of hemidiaphragmatic paresis associated with interscalene brachial plexus anesthesia as diagnosed by ultrasonography. Now, recently, there were few case reports about the magic technique of nerve-sparing regional anesthesia for pain management or for regional anesthesia for shoulder surgery. And I think there is no, so far, any strong study recommends that we can use interscalene blocks for shoulder surgery in patient with at least moderate and severe stages of COPD or gold 3 and 4. But there is still a lot of discussions, few case reports about these new approaches with phrenic nerve sparing effect. But I would be surprised if something comes quick soon. So Smoking cessation, this is now we are in the third box, which was A, B, C, the down left box, which is how to plan and optimize your patient. As I said, smoking cessation is the first advice, the most strong advice you have to give to your smoking patient, particularly if he's a COPD, because it carries lower mortality if he stops 8 weeks before the surgery. So 8 weeks, remember this figure. If the patient is cooperative enough, preoperative chest physiotherapy. If he has a chest infection, you have to send him for the pulmonologist to treat him by antimicrobials, optimize his beta agonist, and give him anticholinergic. You can give those in the day of surgery, but please be aware of back-to-back NEPs is not a good option in the day of surgery because it will precipitate his arrhythmias, particularly with the induction. So one dose is good enough in the day of surgery just before arrival to operating theater if your patient is COPD. And we're talking about 2.5 or 5 milligrams of salbutamol nebulization. And if that did not happen, we have a nice invention, which is a 50 cc syringe. Okay, but we are not injecting the salbutamol with this syringe. We're using the puff or the inhaler and taking out of its box and putting in the 50 cc syringe and attached to the small nozzle a 14 gauge IV cannula and use that as injector to be used in his endotracheal tube. So you can give him 3 to 5 puffs in the endotracheal tube if he didn't get a beta agonist, beta-2 agonist before the surgery. Anticholinergics are good, but still they dry the mucus and make him mucus plugging and may precipitate atelectasis more. So I would avoid anticholinergic in the day of surgery. Or if he got his anticholinergic, you can maintain his good hydration, which is a bit tricky because if you are overhydrating this patient, again, this increasing intravascular, extravascular lung water will be a bit challenging in extubation as well. Steroids, remember that this patient, if he is on prednisolone at home, you need a stress dose of steroids in the day of surgery, and the 5 milligram prednisolone can, if this is routine of the patient, 5 milligram of prednisolone per day, you can give him hydrocortisone 50 milligrams as a stress dose of steroids, not 100. 50 should be enough. Okay. The options, again, if the epidural analgesia is an option in this patient, it's a fantastic pain-free post-operative period. So if you use that, it will help a lot in pain management, decreasing the narcotics or the morphine used post-operatively and helping the balance between pain-free and respiratory depression or depressant effect of the narcotics, which will facilitate his extubation easily. I'm aware and conscious of the time, so we'll go a little bit faster here. So anesthesia conduct now. You need to mention in your consent, which I know that most of anesthesia procedures are running and depending only on the surgical consent, but you need to mention before you put your patient asleep that there is a possibility of postoperative mechanical ventilation, particularly if he's a gold 3 or gold 4, and there may be like longer periods of and challenging period of extubation after the surgery, particularly if it is dorsolumbar surgeries. Pre-medications as well, bronchodilators, antimicrobials, if the patient is on baseline antimicrobials, which is a lot of patients from this kind are on, you will maintain his baseline antimicrobials plus the surgical prophylaxis. Blood cross-matching and type is really related to the surgery. It's not related to the COPD. But you make your transfusion trigger always the 7 because of his hemoconcentration and his polycythemia in the beginning. ICU and HDU bed is required for any gold standard more than 2, so 3 and 4. Room setup, the position is the same for any surgery, but consider if you're giving regional anesthesia and the surgery is long time enough that you make sure that this patient can stay in that position. Particularly, you cannot give any conscious sedation for this patient. Otherwise, you would end up with hypoventilation and deeply comatose, airway not protected, and you will need to intubate him towards the end in a bad circumstances. So plan ahead what you are doing. Lines, as I said, a line awake for sampling baseline, intra and post-operative, and dispatching decision. So if you find your baseline is 6 kilopascal, his CO2 6 kilopascals, and now post-operatively his CO2 is 10 because of residual effect of narcotics or whatever reason. Now you know that this patient should be in a monitored area like step down or high dependence unit. Central line will be left as for the surgery more than anything else. Again, induction, regional anesthesia, opioids, I prefer, and it's always in the text, that you should prefer short-acting opioids rather than the long-acting opioids. And there's a very fine balance between good analgesia and respiratory depression. You can use magnesium sulfate as an adjuvant. It will be very helpful in the bronchodilation and adjuvant analgesia. You can use ketamine as well, particularly if your patient is middle age group up to 65 years. You can use ketamine freely, so it will help as a bronchodilator, good analgesia. So multimodal analgesia with the lowest amount of long-acting opioids. So we'll continue here again with the anesthesia conduct, airway and breathing. Use the largest endotracheal tube size to allow suction and the bronchoscopy if required. Put your endotracheal tube when the patient is deep enough. So BIS monitor is preferred to confirm your patient is deep enough in case UT develops bronchospasm. Ventolin puffs again with the 50 cc syringe connected to the 14 gauge IV cannula. I mean the cannula, the plastic cannula without the needle, and this will give 3 puffs through endotracheal tube. Magnesium sulfate, deep in the anesthesia. Extubate your patient pain-free, wide awake. Again, if the patient had developed any VQ mismatch intraoperatively discovered by your blood gases, always consider your atelectasis as the main indication for that, and mucus plugging. So do some saline nips, do good suctioning, increase the PEEP, but be very judicious with the PEEP because if the patient has a bulla, it may rupture. Avoid high FiO2 to avoid the absorption atelectasis. Avoid the hypoxemia and hypercapnia. Ultrasound is very helpful in diagnosis and differential diagnosis between a chest infection and atelectasis, between the static and dynamic air bronchograms, if you are aware. Okay, if the patient has a sputum plugging, the key diagnostic point here is you find normal plateau pressure with a high peak airway pressure with a difference more than 10 centimeters of water, 10 millimeters of mercury. So if the difference between the peak and plateau is more than 10, with the plateau normal and high airway pressure, high peak airway pressure, this is a resistance problem in this patient. Consider sputum plugging. Again, do some saline nips, humidified air, good suction, and recheck his airway pressures again. Pneumothorax, if this had happened, you need to again diagnose it. Again, you will find the plateau pressure is high, plus the peak airway pressure will be high. So this is a compliance problem. Okay, you need to minimize your PEEP and do fifth intercostal space mid-clavicular, second intercostal space mid-clavicular line, needle decompression followed by fifth intercostal space anterior axillary line, decompression by intercostal drain. So you have still to keep monitoring continuously your peak and plateau pressures. Circulation, again, you need to be very judicious with your fluid management. So look at the trends of the patient. Look, if you have an arterial pressure, you can look at the PIP or the pulsatility index, and if there is fluid responsiveness or not. Look at the jugular veins. If it was starting by flat and now it's congested, the patient looks congested. So look at the trends all the time. If you have a central line, look at the CVP in the beginning on the same PEEP, and then look at the end if your patient needs fluids or not. Be again using all the parameters together, clinical and radiological. For maintenance, you need to put your patient at full exhalation time. So keep IE ratio 1 to 2 or sometimes 1 to 2.5 to allow for full expiration. The monitors should be according to the AEGPI guidelines, but again, I recommend always put on the ventilator the pressure, volume, loops, and curves. Here, this is the difference between auto PEEP and no auto PEEP. This is the flow curve, so it's the flow and time. If the flow is going to the 0 and then starting a new cycle, there is no auto PEEP. If your flow is not reaching the 0 and then starting a new cycle, that means there was a continuous flow, patient was still exhaling, and then you started here a new cycle before the end of exhalation. So you need to prolong his expiratory time until this happens completely, plus the bronchodilators, plus the magnesium sulfate, plus, but you need to keep an eye on the flow time curve. And here, this is the flow volume curve, or the flow volume loop, if I use the correct setting. So normally it goes here, expiration goes to the 0 and then start a new inspiration and then go to the expiration to the 0. So if you find your volume flow loop is ending here, then starting again the new cycle before the full exhalation, this is an indicator that this patient has an auto PEEP. So the treatment here is again bronchodilators, increase the expiratory time, decrease the respiratory rate, allow him to exhale first, and you may allow for some permissive hypercapnia, because if this air trapping or auto PEEP happens, you'll find your patient suddenly became shocked, and if that happens, you need to suddenly disconnect from the ventilator to allow all the air trapped in his lungs to leak outside the lungs. This is in case of emergence of the patient and patient has started to be hypoventilated. You can have a look with ultrasound diaphragm here to, this is, you can assess diaphragm with thickness, you can assess diaphragmatic thickening fraction and diaphragmatic excursion. And this is in particularly if you used the baseline of the patient and you did interscalene block or regional anesthesia, and then you send the patient outside in the recovery room and you find the patient is hypoventilated, you want to rule out the phrenic nerve paralysis. So if you have his baseline before your block on the diaphragm, you can repeat that and compare your baseline to what's happening after to see if your phrenic sparing regional anesthesia had worked out or not. You can add ABGs and chest X-ray as well to see if there is any ruptured pulla or anything as a cause from his COPD. This position of this patient, I prefer this patient to be in HDU, high dependency unit, if they are GOLD 3 or 4. Sometimes you need even to send them to the ICU, mechanically ventilated, intubated for 1 or 2 days. But keep an eye on early mobilization of this patient, good hydration, good analgesia, allow him to breathe as fast as you can spontaneously and get the tube out as fast as you can. Maintain normal PO2 and CO2. DVT prophylaxis is not only chemical prophylaxis, it's the early mobilization and the good hydration of this patient. So I'll end up here with a Chartis procedure or Chartis assessment for endobronchial valve treatment. So the idea, if you have a bulla in the chest, they put a valve, one-way valve that allows air to leak out of the bulla but not in. So this is a one-way valve here that allows air to leak out from this bulla and no air allowed in. So they want to discover if we put this valve, is the fissure between the upper and middle loop or the middle and lower loop, is this fissure is an intact fissure, or there is not, it's not an intact fissure. If the fissure is not intact, actually, there will be leakage from the fissure from one loop to the other loop. So this will be a failed procedure because the valve will be functionless because the air is coming from another loop. So the whole idea of this Chartis assessment is to detect if my loops are intact loops with the fissure intact or not. So this is the balloon that they put here, and they keep this balloon inflated, and the balloon is actually accompanied by a fenestration here at the side of this one, so it allows air to leak outside but no air going in. So it is the same function of the valve, but there is a sensor here towards the inside, allowing to see if there is any flow coming back or not. So here you see there's no flow, sorry. So if there's no flow coming, the flow is going one way, that means there is no air coming via the fissure from the other loop. So this is a predictor of successful endobronchial valve treatment. If you find this is the shape, so there is still flow, and they will leave that for 3 to 5 minutes, and still there is flow coming in and out. So this means the fissure is not intact. So if you put a valve in this patient, there will be of no value. So you're just exposing this patient to the surgery without any benefit. So this is what we call it's a new procedure. This is one of the publications in 2020. It's a very new procedure, but it's gone viral because it helps a lot of patients and it improves pulmonary functions after this bulla surgery. It's like a medical bullectomy rather than surgical one. So it is accompanied by better post-operative mortality and morbidity compared to surgical procedure. You can read more about this one. I think it's possible to have it in one of your exams if they are interested with the new procedures. And I hereby finish my talk, and your questions are very welcome. Thanks very much for listening. Okay, so I have a question here, says, what is ample history? You can easily Google it, but it is taken as either allergies, medications, P, past history. You can classify that as past medical and past surgical under 2 items. L is the last meal in case of emergencies. You consider your patient is still fasting. E is the events related or events caused this patient to come to anesthesia. Is a surgical procedure in an instance. Like if he's a trauma patient, how did he fall? Did he lose his consciousness? If it is bowel obstruction, since how long? So you get details about the surgical procedures that's going to happen now. Okay, let me see if there is any more questions here. Okay, I hope you're satisfied now, A'timad, about my answer about ample history. Could you describe again the method of administrating Ventolin? Yes, so the Ventolin is coming in a buffer, okay? If you remove this buffer, you will find the buffing vial inside. So you will apply this one between the plunger and the syringe. So you will open the plunger and put this vial inside. And then you will put the plunger in back again, as if you are injecting the drug. But you are not injecting that intravenous. You will attach the cannula, which is 14 gauge cannula, without the needle to the nozzle of that syringe. So this will create a syringe with the buffer inside, and this cannula is attached anteriorly. So you can put this inside the intracheal tube, reaching almost a third of the distance of intracheal tube, and give 3 to 5 puffs of this Ventolin nebulization if the patient develops a bronchospasm. This is one of the treatments of the bronchospasm if it happens intraoperatively or after intubation, plus the magnesium sulfate, plus the ketamine can be used, plus the sevoflurane definitely. Sevoflurane is one of the very important potent drugs of bronchodilation. Okay, I hope that's answered. Can you repeat the correction from, okay, so the correction from kilopascals to millimeters mercury is multiplied by 7.5. So I know that most people in the Middle East are using the millimeter mercury. You can, like 4 kilopascals are 30 millimeters of mercury, or 6 would be 45. So that, because we are using in Europe the kilopascals, not the millimeters mercury. Best analgesic plan if epidural is not possible. Thanks, Muhammad, for this interesting question. So it depends on the procedure you are doing. So every procedure has its analgesic plan, but I think multimodal analgesia is the idea behind. So always use paracetamol routinely 6 hourly in the post-operative period, 48 to 72 hours. Always use multimodal analgesia in the term of add magnesium and intraoperatively 20 to 30 milligrams of ketamine. Use short-acting opioids for COPD patients. You can use long-term opioids in a minimal dosage, plus the regional anesthesia and blocks if it is safe enough to do. As I said, GOLD 3 and 4 are contraindicated for supraclavicular blocks, interscalene, or whatever the block you would like. I hope that's answered as well. Can you repeat? Okay. Thanks so much, Dr. Negm. Okay, is non-steroidals contraindicated? That's a very nice question, Muhammad. I really like it. So for asthma and COPD patient, I tend to ask them, did you get any ibuprofen or non-steroidal by name before? How is your tolerance to that? But as I said, this patient is usually a multi-comorbid patient. So you may find another renal disease, coronary artery disease, previous stroke. So if you find these comorbidities, I would try to avoid the non-steroidals as much as I can, but it is not absolutely contraindicated if the patient is getting them before and tolerated them. Okay, so two physicians, two colleagues asking about the same question about magnesium sulfate. What is the dose? I'm giving 2 grams of magnesium sulfate as routine. That can be doubled provided you need to. So the baseline is 2 to 2.5 grams of magnesium sulfate in a 100 ml bag. Okay, that can be infused over 30 minutes or maximum 1 hour. So like it's a safe drug, provided you keep an eye on the blood pressure. If you need to repeat that, it's fine. You can repeat that up to 5 grams. If you need to repeat more than 5 grams, I would advise and strongly advise you do the patellar test. Before you do that, if you find any hyporeflexia on the patellar reflex, don't do that again, or you have to monitor his magnesium sulfate, his magnesium levels before you do that again. Okay, so and do an ECG as well. To IV bronchodilators, yes. So the current evidence says that the IV salbutamol and aminophylline and all these drugs are not superior to any of the medications we give. And I feel that the challenge about the bronchodilators may be in emergency department, maybe in the medical ward, but not in anesthesia, because in anesthesia you have the magic drug, which is sevoflurane. So sevoflurane is a strong and potent bronchodilator. If you combine that particularly with the magnesium, ketamine, and other drugs that we have, I rarely needed to give the aminophylline or salbutamol as IV. I rarely require that. I think it's once in my life as a whole. Ketofol dosing infusion, I am not familiar with ketofol. I think ketofol is like as a preparation pre-mixed together is only available in the States. To my knowledge, I'm not sure about that one. I don't have any input in this question. Is all smoking are equal like vaping and shisha to cigarettes? Yes, I can say cigarettes is the worst comorbidities in the term of mucus production, and mortality and morbidity was done on the cigarette smoking and shisha smoking. But the recent vape, I had seen reports that's catastrophic on the vape. Vaping is a killer in different modality, which is you don't know what is the content of the vaping actually compared to the cigarettes, and there's a lot of anesthesia-related mortalities in young people with no other comorbidities. I had read a lot of reports myself, so it's worse, much worse compared to the cigarettes and shisha. Shisha smoking, because of the long tubing system, causes more COPD and causes bully formation quicker than cigarette smoking. But I think I don't know, I'm not really aware of the difference between them. Dexmedetomidine, I think that dexmedetomidine has a tiny, if any, bronchodilator effect, so it can be added as an analgesic if you're asking about the analgesic effect, but again, very weak analgesia. You can add clonidine or dexmedetomidine as part of a multimodal analgesia, but I don't think from analgesia point of view it adds a lot. Okay, if an O2 developed, how you manage? Okay, the first thing you need to do is to release the tube from the ventilator to allow this trapped air all to leak outside before you do anything else. Number 2, you need to allow for less respiratory cycles to decrease the respiratory rate, increase the IE ratio, and treat the underlying cause of the auto-PEEP, which is the bronchospasm. How you treat that is bronchodilators, as I said, bronchodilators, salbutamol, and anticholinergic like ipratropium, magnesium sulfate, and ketamine, sevoflurane. All this can be used as bronchodilators. Whatever you want to do that, but you need to do something with very quick effect to allow as low expiratory rate as you can, and you can even allow for permissive hypercapnia rather than air trapping and barotrauma. Can I have a record of this presentation? Definitely. Thanks so much. All the presentations and all the lectures are available in savinglivesacademy.com, hopefully soon, inshallah. Thanks very much again. Thanks, Dr. Walid. Do you want to ask anything, Dr. Walid? If you unmute yourself, please.
Shukran, Dr. Walid.
Great presentation. Thank you. Thank you.
Thank you. Dr. Magdi Khalil, please don't ask. Do you want any questions?
Very fruitful information.
Thanks very much. Dr. Hazim Yassin, our colleague here, thanks. We see you after a long time again. Very good to see you. I know you came for me. Thanks so much. Any questions? Okay, perfect. So now I think I forgot actually to put the polling for the second lecture. So I put the poll. Forgive me if I didn't make it that good. I leave this poll for just 1 minute and then we'll close. During this minute, any comments, please feel free. Dr. Magdi, Dr. Hazem.
No. Thanks a lot. See you next week, inshallah.
Okay, see you next week, inshallah. And I don't recall what are the lectures of the next week, but I think there is an interesting lecture by Dr. Ahmed Abdel Menaim, Anaesthesia for thoracoabdominal aortic surgeries. So he is one of the interested people in this field. So I'm sure you will enjoy that. Okay, so perfect. So I'm ending the poll here with 83% voted. Thanks a million. Thanks very much. Very good. So see you next week, inshallah. Assalamu alaikum. 1 second, just one question here. Oh, thank you. Okay, perfect. It's not a question. So thanks and see you next week. Assalamu alaikum.